Well, hello, everybody. Good morning or good afternoon, depending on where you are in the country or in the world. My name is Garrett Schmidt. I am the managing editor and CEO of VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by DataLink, and it is called Transforming Care Management with AI. It's risk stratification and predictive modeling for better health outcomes. A lot of interesting things we're going to be discussing today. So very excited about the presentation. Everyone has joined today in listen only mode. So this is a traditional webinar format. You don't need to worry about turning off your microphone or your camera. That has been done for you. So all you have to do is listen, but we do want to hear from you, and we're going to have some time for some Q&A towards the end of the presentation. And if you have a question at any point for either of our speakers, you can use your attendee module. There's a place for questions. So you drop your question in there. We're going to get to as many as we can during the allotted time. If for some reason we're not able to get to yours, don't worry, someone will reach out via email afterwards to make sure that we get your question answered. So even if we're wrapping up at the last minute, go ahead and ask your question. We're also going to have some polling questions today, so you can play along at home. These are anonymous, and so you can feel free to answer accurately, and we'll show the results, but it's a way that you can kind of get involved in what we're doing today. So and then finally, we are recording the session. So what's going to happen is when we're done, you will receive an email about an hour or so after we conclude, and it will have a link, maybe a little bit longer than an hour, but sometime today, before end of day, you will receive an email, and there'll be a link to where you can see the recording. You can share it with colleagues if you would like. There's also going to be a place there where you can download the slides from today's session. So all of that will be at that link. So without further ado, I would like to briefly introduce our speakers today. We have with us Mr. Saurabh Bhargava, and he is the Vice President of Data Science. And we also have Priyank Jain, and he is the Director of Data Science. So welcome, gentlemen.
Thank you so much, Garrett. And hello, everyone. Today, I am excited to discuss about AI transformation for care management, specifically through risk stratification and predictive modeling, which is helping us create patient risk scores and identify patients, how to identify them before they escalate, and also to create personalized intervention plans uh, and allocate healthcare resources and ultimately improve patient care. Uh, so, good morning, good afternoon, good evening, everyone, depending on where you are. It's a pleasure to be here today. My name is Bhargav, a data science leader with more than 2 decades of experience in healthcare analytics. Throughout my career with healthcare analytics, I've worked across providers, payers, and life science companies, looking at enhancing patient outcomes, improving the and optimizing operations, and driving innovation. By my educational background, I'm a health economist and an MBA, and for the last 18 months with DataLink, leading the data science practice. My focus has been to develop AI-driven solutions for payers and providers for risk stratification, care management, as well as financial planning through NLP for chart reviews, generative AI, conversational data insights, as well as for predictive analytics for population management. Before DataLink, I spent several years at a United Health Group and Optum, leading analytics teams for multiple businesses, be those member advocacy, Optum Care, clinical operations, and life science consulting. Today, I am also joined by Priyank, and I'll let him introduce himself.
Hi everyone, I am Priyank. I am Director of Data Science at DataLink. I've been developing AI ML based solutions for the past 16 years in the healthcare domain. Right now, we are working on several AI ML advanced solutions for risk adjustment, care coordination, all the basic areas of operation in the healthcare domain. Yep, that's pretty much it about me.
Thanks, Priyank. A quick brief on DataLink. And DataLink is a leading health tech company leveraging AI-driven data-powered solutions. And for last 20 plus years, we have integrated technologies that provide actionable insights, automate workflows, and enable seamless data interoperability. Our solutions are empower value-based care, optimize quality, and ensure risk accuracy with financial planning, working with different stakeholders, different clients across the healthcare spectrum. And today I'm excited to share insights on how AI is transforming care management, helping us move forward with a more proactive, data-driven, and patient-centric outlook. Uh, I look forward to for this engaging discussion on how we are collectively harnessing, how we can collectively harness this technologies and address some industry's challenges. So while I'm talking about challenges and I go into further talking about risk stratification and predictive modeling, let me just talk a bit about the kind of challenges I'm addressing out here. The kind of pressures that healthcare industry is itself going is from the rising cost, the workforce shortages, as well as the inefficiencies in resource utilization. These challenges are not new, but these are, and also not just operational, but these are directly impacting patient health and satisfaction outcomes, or provider efficiency and the overall healthcare sustainability. And that's why it becomes pretty important just to lay them out before going and trying to solve that whole problem and discussing about it. The healthcare spending in US has been surging. Nothing new about it. It has been for a few years, but from 2022 to 2023, 7.5% the overall healthcare cost went up, straining budgets not just for payers, providers, but employer groups also. So budgets are tightening everywhere. Costs are rising across all lines of businesses and spending categories, be it hospitals, be it PCPs, or be it the life sciences, other drug consumption too. And calls for more smarter cost containment strategies. Um, this is now accompanied by a shortage in skilled professionals, and skilled professional is not keeping in pace with the demand that is coming with a higher requirement for healthcare. This shortage is well researched, documented, that there is a shortage for physicians, especially for PCPs, which is leading for physician burnout and low patient care. And there's a projected shortfall of about 124,000 physicians, making it difficult to provide timely care, looking after the high workload that comes along with that. Therefore, choice or selection has to be made about providing right healthcare to the right patient at the right time. An effect of this has been there, and that leads to some unwarranted utilization, which is a symptom of systemic inefficiencies. 10% of the population utilize 30% of healthcare expenditure, but still a good 90% utilize 70%, which demonstrates the spread. The utilization happens across board, and hence it requires a pinpointed precision. Data has also been reflecting that 1 in 5 readmissions after surgery are potentially preventable, highlighting the gaps that exist between the post-acute care and care coordination. Alongside with that, another problem is the two-thirds of the hospital ER visits in commercial population are avoidable, often are driven by gaps in care coordination or lack of proactive interventions. Now, when we look at these challenges, it underscores the urgent need for data driven decision making to optimize care delivery, reduce avoidable cost, improve patient outcomes, and AI and predictive analytics do offer a path forward with them through providing a framework which is for identification, intervention, and coordination. Uh, let's just take a quick break and see our first survey.
Okay, so we have a polling question for you, and it's going to appear on your screen right now. So, and the question is, where do you think risk stratification helps most? And this is a pick one that best applies. I'm sure it'll help in all these. Is it care planning, coordination, intervention planning, financial planning, or all the above? And we'll give it about another 10 long seconds for everyone to place their vote. Okay, I think most of the results are in now, so I'm going to go ahead and close it down and share the results. Okay, Sarab and Priyank, are you able to see this on your screen?
I can see the results, yes.
Okay, so I'll just read them real quick. So care planning and coordination, financial planning, 4%, and all the above, 73%. The clear landslide winner.
Absolutely right, and that's how risk stratification is currently being used, and that's where I'll just take a quick one. Um, so, how can we use AI to address these challenges? Uh, we use risk stratification or risk scoring as terms interchangeably, but in principle, it is a key component of population health management, where we need to understand who needs more care and which conditions require intervention before they become complex. And now, risk stratification can be pretty simple. Example, members who have high BMI are smokers and have blood pressure are high likely to have a heart condition. This is stratification. This is simple stratification that I stratified members with a high risk for a heart condition against members who are low risk than those. We can create general risk models for population or can create specific risk models. Example, risk of readmission, which is a LACE, or a survival with comorbidities, which is Charlson's comorbidity index. Now, the risk stratification using rule-based models are highly explainable. Uh, they provide basic scoring mechanism to achieve managing population separation in different risk buckets, and that's the best part about those rule-based. But even in rule-based, there could be a bit of a complexity, something that with there these could be non-linear interactions, something what we have seen in HCC models, wherein multiple conditions are interacting with each other, and these are configurable. These get enhanced. These can take a lot of considerations of disease conditions into place. And but they can be used for payment mechanism, for care coordination, for financial planning, and so on and so forth. So the purpose is also defined stratification we are talking at the level of complexity we are in. However, with newer data coming in, machine learning models are able to generate better segregation in patients. And this is what we are going to understand today. The endpoint for the risk stratification is that it will categorize patients based on their clinical and medical history into high, medium, and low risk for generalized or a specific adverse event. It does not require the population to be categorized only for um, uh, generalized risk, but it can also go deeper into specific risk like readmission or ER predictions too. So, just moving on. Risk stratification helps us categorize patients into different risk tiers. What we discussed about the high, medium, and low, there could be multiple categories further given into it, emergent, or it could be more complex, and so on and so forth, allowing providers to focus on who they need to see and where do they need to spend more attention in. They can focus on the high, which are already very complex, and but the savings could be less, but they would want to focus on patients which are more emerging or into the medium risk categories, and it depends on the outcome, or they have programs that are specific and they would want to look at those specific programs. And AI based risk stratification, what it does is utilizes more data. It looks at a member from a holistic point of view. It looks at member with multiple data parameters or data variables that were not considered in other rule based. For example, it can look at your exercise data, it can look at your smartwatch, it can look at social determinants, which is an important and integral part in terms of defining the risk for a patient. And apart from being utilized for patient prioritization, plan design, risk stratification can help improve care coordination through early identification and helping to reduce the adverse event for the high likely population, utilizing limited resources, something what we were talking about. Either we are looking at a members holistically and saying a generalized risk model that could differentiate and classify members into different groups. But it can also cut across these various groups and say, we are looking for a specific population. For example, risk for readmission. We are only looking for population which has a high risk for readmission, or we are only looking for population that has a high risk for fall, and so on and so forth. So with that introduction for risk stratification, let's look at a quick second survey and think about how AI-based risk stratification is something impacting all of us.
Okay, so once again, you will see this on your screen. Have you used any AI risk stratification solutions? And what did you use it for? Was it generic risk or outcome specific, readmission, ER visit, or some other? And if you have done both, perhaps maybe the one that you use more often or have used most. And we got results are still coming in here, so okay, I think most people have voted at this point, so oh, well, it keeps coming in. So we're going to close it down in probably another, let's say, 10 seconds or so. We'll close it down in 5, 4, 3, 2, and 1. Okay, and the results are for generic risk, 42%. Of you said that you used AI-based risk stratification for that purpose. Outcome specific was 64%.
That's wonderful. I think a lot of the people in the audience are exposed to it and have been using, which is great. So that allows me to move next. Uh, and Priyank, will you take over?
Yep. Thanks, Saurabh. Yeah. So we have seen there are several ways in which risk scoring can be done. There are several algorithms, there are several use cases. And in general, it has been found that the AI ML based machine learning models are slightly better when it comes to accuracy and performance of these models as compared to the traditional rule based models. Now, there have been several studies, and one such study was done by Biomedical Center for Health Research in 2022, where they compared the LACE scores against various machine learning based models, where both the models were trained to predict readmissions. And as the results showed, the machine learning models fared well compared to the LACE models. And there are several reasons for that. But in general, and it's not to say that the traditional rule-based models don't have their use cases. They have their very specific use cases, and in those use cases they excel. But in generalized practical sense, the AI machine learning based models fare well. But it's not just the performance that we need to compare of these models. There are other aspects as well, like interpretability. So the traditional rule based models like LACE, for example, the interpretation is pretty straightforward. There are rules, either the rules apply or they don't apply, right? So the interpretation is straightforward. For the machine learning models, however, there is a complexity involved here. We have to apply additional methods, additional statistical ways, logical ways to make the models more explainable. So there goes in a extra work there for the machine learning models. But on the feature engineering side, if you consider the number of features that these models are considering for their inputs, for example, LACE only considers 4 features, which is very limited, and its output is also limited towards readmissions. While the machine learning models are very flexible in this aspect, they can ingest any number of data elements, any type of data elements, and it can utilize all the interactions and combinations pretty well. Now, predictive performance we've already seen from the study conducted by the BMC, and it shows that predictive performance, the ML models are often superior as compared to the rule-based models. Then comes the adaptability. Now, adaptability is very important for these models. The traditional rule-based models, they have very specific use cases like LACE. For example, is only used for readmission predictions. And there are several other cases as well, like HCC models. They are used for reimbursement purposes. But the machine learning based models can be trained for n number of things. It's just the outcome that you have to train the model on, and it will start predicting that. So the adaptability is enormous in the machine learning based models. Finally, it comes down to the computation cost. Now, computation cost on the rule based models is pretty low because they are rules. It's like if and else statements. You can apply n number of if and else statement without going after your machines, right? But for the machine learning models, it requires higher compute for training, higher compute for predictions, and all these things are there. However, and that being said, because we are in today's day and age, the availability of compute and the cost at which it is available is both manageable, and hence if you're not going into the realm of genomic data sets and those high value data sets, we are good in either case. So this point just applies when we go to the higher level models. So basically what we are trying to establish here is that machine learning AI based models are practically better in most of the scenarios when compared to the rule-based models. Now that brings us to the next slide. Yeah, that brings us to the next slide where we are introducing the data links AI-based risk stratification, where we are trying to assess every member's health based on their clinical, their social, their demographic, and their transactional data. Now, we also conducted a small study to compare it with one of the more popular models, the HCC-based risk models. And I mean, the thing is that both these models have a different purpose. HCC model is created by CMS for reimbursement purposes, while the data link model is more towards assessing the health. So in a way, it's not like we are trying to say that one model is better than other. It's just that we are trying to compare these models from the perspective that both these models are looking at the overall health journey of the member, and in that way it's a fair comparison. So we are trying to see two things here, and what we did was we synthesized the data. We synthesized a small data for 9,000 members, and this is as close as it can get to the actual claims data that we have in any real world scenario. And we gave this data to both these models to break down these members into three categories: a low risk category, a medium risk category, and a high risk category. Both these models did that, and you have the first row of tables depicting that. Now we wanted to analyze these models on two basic parameters. One is the separation between these categories, how separated the low category is from medium and the medium category is from high, and how homogeneous these individual categories are within themselves. So let's consider the first parameter, which is separation. Now if you consider the second row tables, this throws a lot of insights, or give you a lot of insights on the separation of these models. So the first table that you see in the second row is the data link AI based model, and the second table is the HCC risk model. And let's concentrate on just the first parameter, which is the average cost per member. So the average cost per member in the low category for the AI model is $439, which is way far away from the high category, which is $31K. Now this separation reduces in the HCC risk model. If you see the low category, the average cost per member is around $2,000, and in the high category it is around $22,000. And you will find the same insights across all the different parameters that we have shown in these two tables. So basically what we are trying to say here is that there is good separation that the AI models can bring in when they create categories, and these separation are pretty evident when compared to other traditional models. Now the second category, or second parameter that we wanted to analyze, was homogeneous or homogeneity between within these categories. So let's consider the first Venn diagram, which is the low category, low strata. And in this category, both those models, the HCC model categorized around 2,700 members, and the data link model categorized around 3,400 members. Both of these models agreed on 1,756 members, and these 1,756 members had an average cost of $390. Now consider the additional 970 members that the HCC model thought were low risk. If you consider their average cost, it is around $4,784. So basically it's like they are quite far away from the overlapping members. Now consider the additional 1,689 members that the AI risk model put in the low category, and their average cost is around $489. So the homogeneity in the low strata created by the AI risk model is much higher than the homogeneity created by the low strata created in the low strata by the HCC model. And you can find similar insight in all the three Venn diagrams that we have shown here. We compared a lot of results. This is just the tip of the iceberg. There are a lot of things that we compared, and in most of the results, almost 99% of the results, we found that the AI driven models have an edge. Moving on to the next slide. Now, the point is, and we have already discussed this as well before when Saurabh was talking about the risk stratification. So risk stratification can take us to, prioritizing the members or maybe optimizing certain plans. What after that? So that brings us to Rapier. Rapier is a platform that Datalink is developing. It's a population health analytics platform which combines cohort building, and it's a redefined cohort building that we are bringing up here, which is based on machine learning. It combines cohort building with risk stratification, which helps us identify or isolate the problems pretty accurately, and it enables precise analysis. And I'll talk about the concept in more detail in the illustration below. So imagine you have a population where you are experiencing that the overall ER expense has increased by 20%. Now, what once you give this population to our cohort builder, it will go into this population. It will try to identify smaller subgroups where this ER expense is concentrated. And in one of the examples, we found out there are two subgroups. One subgroup where the ER expense had gone by almost 100%, and the other subgroup where it had gone by around 120%. Now that's not it. I mean, the cohort builder, the machine learning based cohort builder, not just stops at that, it also gives you the main reasons. The main reasons for the first category was the statin non-adherence, and the second category was severe heart problems. There were other reasons as well. These are the top reasons. So this cohort builder, imagine this cohort builder overlaid with the risk strata now. So you have the risk stratification, which tells you about the high, medium, low risk members. Overlay this cohort builder exercise on that risk stratification, and you get the third diagram here, which tells you that there is a particular, so one of our cohorts lie in the low risk population. So these are low risk, high utilizers, which gives us the insight that there is a higher scope of improvement here. We can improve, and it not just stops at that, because it told us that these are statin non-adherent people, most of them are. So we have a direct intervention strategy where we can directly go to these people, have them do more provider visits, have them be adherent on their medications, and we can avoid these visits, avoid these ER visits. Yeah. But on the other side, we have the high risk, high utilizers, which are people who are high risk and they are going to ER because of heart problems. They might be genuine users. So it gives us an insight. Rather than applying the interventions on the whole population, we can apply the interventions in a very prioritized, directed way to the high risk, low utilizers first, and then move on to the other categories. So this is just one use case. There are several use cases that we can do, and we have been working on a lot of cohorts, which we'll talk in the next slide. Okay, so we have been working on a lot of cohorts. There are clinical cohorts like, high risk chronic conditions, there readmission cohorts, non-adherent cohorts, behavioral health cohorts. Then there are financial cohorts, which are based on utilization, like high ER utilizers. There are medication over utilizers. There could be fraud, waste, and abuse. There could be, people who are overusing imaging and diagnostic facilities. And it's not limited at that. The users can create. Rapier provides a mechanism where the users can create their own cohorts, whatever problem they are facing. They can create those cohorts and even extend this cohort building mechanism to providers. So it's an open field where there are several cohorts which are pre-built, but there are a lot of opportunities to create cohorts and analyze them as accurately as possible. Now, this brings us to a point where we are addressing the problems which are already existing. So it's a reactive intervention. Rapier doesn't stop at reactive intervention because we have done so much analysis in the data. Right now, we have the current cohorts, we have the member data. And these current cohorts have their features. They have certain features which distinguish them from the other members in the data, right? So we have machine learning models that can learn those features, that can utilize those features to identify prospective cohorts. So Rapier will allow you to identify prospective cohorts from your population. These are people who are going to be in the same situation as these current problem cohorts are, and then you can apply proactive interventions. And one of the use cases we have below is related to non-adherence cohorts, where we first of all identified the current cohorts who are non-adherent, and then we identified a population of people who are very similar to these current cohort people. They are still adherent, but they have a high propensity of non-adherence, and we identified this with a almost a 90% accuracy. So this opens up the field of proactive interventions, and it's a open playing ground now. You have reactive interventions, you have proactive interventions. It brings the loop, it closes the whole loop where you have control over all kinds of intervention that you want to make to your population. That brings us to another survey question.
All right, here we go. Pulling up our last survey question here, and it is: what challenges do you see for AI-enabled care management? And this is a choose all that apply. Explainability or complexity to understand the functioning, privacy risk, integration with existing workflow, cost to build, manage, and integrate, or anything else. If there's anything else, use the question area to drop those into the question box when we get done here with the poll. And just curious to hear what the other concerns are, challenges you see for AI-enabled care management. And it looks like the results are still coming in. So we'll give it a little bit more time here. All right, looks like most people have answered now, so I'm going to go ahead and close it down in probably another 10 seconds. And then we will show you the results. And again, if there's something else that's not listed here, then as soon as this wraps up, go ahead and drop that answer into the questions box, along with any other questions you may have. All right, here we go. Sharing the results. Are you guys able to see this on your screen?
Yep.
Okay, so it looks like, yeah, go ahead.
And I'm really glad these results came in. Go ahead, Garrett. You want to announce those
Oh, I was
results?
just going to read the results real quick. So we had 34% at explainability, 41% privacy risk, 68% integration with existing workflow, and also 68% with cost to build, manage, and to integrate.
And these results are pretty exciting, specifically looking at that more people from the audience believe cost and integration to be the higher challenges, whereas a lot has been spoken about the privacy, the biasness, and the explainability for AI. But definitely, these are more operational things about integration and the cost to manage and integrate. But definitely, this is a very insightful survey result for us. So, just moving ahead, and just to talk about what is that future that we look forward for specifically into the care management. AI's role in healthcare is evolving rapidly, and that's what we all see. We have a lot of use cases, a lot of examples that we are going to continue to see how they are getting evolved. And it's not just analyzing data today, it is actively supporting clinical decision making. And that's where my comment on biasness and privacy and explainability was coming in, that from an AI perspective, how it is currently growing is about clinical decision making, enhancing patient support, personalizing care at an unprecedented scale is something that is currently happening, that is making those changes and inroads into care management from an AI perspective. And specifically with the generative AI, which is generating real time analytics uh, for patient engagement tools as well as for physicians is something that is changing the space wherein we are operating today. Um, from a generative AI, it is looking at clinical decision support by summarizing vast amounts of unstructured data, even to a point it is using voice text to summarize that data for an easy understanding, not by physicians, by patients also, identifying patterns and utilizing it to reduce the operational time that it takes for repetitive tasks. Uh, Generating insights out of that data to be able to predict what's next. From a from the future perspective, the AI-driven real-time patient monitoring is also transforming acute chronic care management for the high risk, high cost patients. Now, by continuously analyzing the vitals, lab trends, and the patient behaviors, AI can detect early warning systems. It is capable of very much capable of ingesting multiple data feeds from a wearable to biometric to the connected device data that is coming in and create right warning signals that a nurse could be managing 5, 7, 10 patients at a distant location. Visual AI monitoring, which is again enhancing that cause of care management by looking at mobility, posture, or distress signals for high risk patients and enable proactive interventions before any crises occur here. Uh, one one size fits all has been something that has been concerned specifically in the healthcare space, and pathways have been designed in such a way that it believes that one medication works for all at the same time in the same format. But AI is changing that, and that's where they are dynamically tailoring treatment plans. It is constantly evolving and looking at patients' unique clinical profile, their genetics, their lifestyles, and social determinants of health. And it is getting embedded within workflows. It's not something of a further distant that this is not being done. This has been done. We utilize these data sets to create some clinical profiles that are very accurate and enable the clinicians to take better decisions. Beyond clinical settings, AI is playing a critical role in patient engagements through chatbots, through virtual assistants, through predictive outreach tools that can remind patients about taking medications or even scheduling follow ups, and even providing self care recommendations based on the real time data. So, while the future for AI in healthcare is promising, there are those challenges. And in the previous survey, we did speak about few of those challenges. It's adoption that would, if we are able to manage that adoption rate and handle the challenges, those are few of the things. The way we look at it is the transparency and trust for is one of a big hurdle in AI adoption, specifically when it relates to clinical decisions making. That decision that has to be taken based on AI-based outputs. Uh, a lot of clinicians and healthcare leaders will have to understand how the AI models generate insights and recommendations before they can trust it. And if AI continues to operate as a black box, that's the term that continuously I have heard for so many years. The AI model is a black box, and if it continues, that skepticism will limit the impact that AI models can bring, and it has the need for that explainability that they have to bring together. Um, Many healthcare organizations, and something that we saw in our survey results just in the previous slide, struggle with integrating AI. The workflows are already pre-existing, and integrating a new tool, a new solution, wherein few of the technology teams might find it difficult to integrate because it utilizes more data, it utilizes better, higher processing into their clinical and administrative process. That limits the utilization, and that's one of the barriers, of course. For AI to drive meaningful change, it must fit seamlessly, and definitely it has to look at the last mile analytics. It needs to continue to be able to integrate, not just create very accurate models, be able to accurately identify or predict the next things, but it needs to identify how to integrate well, where to integrate, and not disturb the existing processes unless it is revamping the whole process. Uh, Last but not the least, one of the most important things that I have throughout seen is the success of a AI solution lies in its measurement. If you cannot measure it, howsoever successful it is, it will not be deployed because everything comes back to those financial transactions, to those financial benefits. What is it that I am getting as a return on investment that we are doing with AI in our organizations? How do we quantify improvements and quantify patient outcomes or cost savings or operational efficiencies? And clear and consistent KPIs is the key to defining what did we achieve. Did we achieve reduced readmissions? Because everything has to be in those numbers. And unless we have a mechanism while we are implementing and deploying these AI models, unless we put up a system which relates to the patient or the provider, we are not going to benefit to the maximum what these AI solutions will be able to bring. Um, the future isn't about implementing AI, but ensuring it is trusted, it is integrated, and it is impactful. And with this, I will end my presentation and open up for any questions that I may get from the audience.
Okay, wonderful. Well, thank you both, and we do have some time for some Q&A. So if you do have a question for either of our speakers or just in general, go ahead and drop that in now using your attendee module, and you will see a space for questions. And we're going to get to as many as we can. A couple questions here just to get started is, first one is this: how do you compare or establish if the results from predictive model are good or can be used, are good and can be used?
Okay, so let me take that up. So it's usually dependent on the use case we are applying that model to. So sometimes the use case needs that the accuracy or the, we cannot leave out anything. Anything which is positive, we cannot leave out. There cannot be any false negatives. So or there could be a scenario where we cannot have any false positives, right? So it is use case dependent. It is very much driven by the requirements of the client. So there are some models like in NLP, there could be some errors which are acceptable because it is missing out on certain grammar things and all those stuff, but it is making out the final meaning of the context, then it is acceptable. But if it is missing out on the context, then it is a problem. So use case is the thing that plays a more important part in how and why we adopt a model or we leave it out. Saurabh, you want to
So
add something to
just
that?
to, yeah, just to add, um, of course, Priyank mentioned about the use case. Another parameter apart from use case is the data. What data is available to you? Technically, when we are building models, we are comparing it to anything that's available as a part of a research. If there is a baseline that we can establish for a model, but those research could be based on a very rich data set. You could have patients' hospital admission data, details about what they were having, what meal plan they were on, let's assume. And this is a real problem statement I'm talking about. So one of the researchers who was doing research about readmission was also able to look at the food that they were having and the calories that they were consuming. And as a outside team, I don't have access to it. So it depends on what data you can have, and that depends on the what model you can build. Now, based on that model, what outputs are you getting, and how will you use it? Something that Priyank did mention. Do you want to create a model for stratification so that you can identify patients who are less likely to go for vaccination? And if you want to run a program which is based on digital program for a digital outreach, then you are happy to have more patients wherein you can do an outreach. Even false positives are okay. But if you want to do a in-person phone calling, then you will be stricter on that because the amount of resources is pretty expensive. So it's a bad model is all dependent on the particular use case and the kind of data that you're looking at.
Garrett, you're
Okay,
on mute.
wonderful. Yeah, I knew that was going to happen. Okay, next question here is, uh, who, in your opinion, are the users for this risk stratification, payers or providers?
Okay, so it's for both. It's the payers can use it for optimizing their plans. They can use it for running targeted outreach programs. They can also plan some intervention strategies, and they can use the risk stratification for all these purposes. But the providers can also use it. Like for a care coordinator, they need to know who are the high risk patients, who are the medium risk patient, who are the low risk patient, and they have to design their own therapies based on that, or how much attention each of these groups need. So they can prioritize their own workflows, their own encounters, their own meetings with these people according to the prioritization and the risk scoring gives. I'll keep it short. I'll pass it to Saurabh to add content to it.
I think you covered it. As we mentioned earlier, it's an integral part of the population health management platforms. So, categorizing and stratifying population has multiple uses, and those uses can lie within a payer organization for various outcomes that they are trying to achieve, to understand from actuarial standpoint, from underwriting standpoint, from contracting standpoint, whom they want to contract, where is that population that is high risk, what sort of risk they are looking at in their population, to a full risk provider organization wants to understand their own population, how to do scheduling, which patients to schedule first, what is that risk that they are running. And that's what it covers from both the perspectives that they are interested to understand what population do they have at hand.
Wonderful. Moving along. Next question here is, we still see a lot of organizations using traditional stratification methodologies. What do you think are the reasons for those to exist when more accurate machine learning algorithms are available?
Okay, so there are several reasons, and those several reasons we also discussed in the slides. Like one of the basic reason is explainability. These traditional models are very explainable, and they apply to certain use cases pretty accurately. Like for example, LACE. LACE is built for readmission, prediction, and the variables it uses, we can, pretty accurately explain that why this person has a higher score as compared to another person, because those variables are right there in front of us. It's specific use cases like HCC is used for reimbursements. So these models are there, they have their own pros and cons, and it's not like any model is bad or good. It's just that that particular use case requires that model. Plus there is an industry inhibition towards AI and machine learning. And since we work in a industry which has very low scope of error, because healthcare is such a domain where the scope of error is pretty low, so the adaptability or the adoption of AI based risk scores is still low, and hence people still rely on the traditional rule based models where they can explain it pretty accurately based on the rules. Saurabh, do you want to add anything?
No, I think you covered it pretty well.
All right, moving along. We have a lot of questions today, so this is great. So again, if you have a question, go ahead and drop it into the module, and we're going to get to as many as we can. Next question is this: it seems like healthcare employees are even more skeptical than other industries in terms of trusting AI generated results. Have you noticed that starting to shift, or what needs to happen to create that shift?
So
Okay.
I can take that one, Priyank, if that's okay. Um,
Yep.
yes, and Priyank mentioned it. There is a very low likelihood and low threshold for any errors in the healthcare industry. It deals with people, their real health, and that's what concerns the physicians who are taking decisions about people's health, people's lives, and that's what makes it a lot more complex. Very low aptitude for error out there. Um, are we seeing some shift? Yes, we are seeing some shift around here, but the shift is slow. And I will say, we have seen a lot more positivity around considering AI to sit there, but it is still being looked at. Okay, let's compare it with something. And that's why what we did today is comparing those populations, comparing those models. How do they score? But continuous monitoring, continuous reinforcement, um, keeping those frameworks and checks on AI algorithms, ensuring that there are biases have been kept under check, the privacy is not breached using AI, is something that is going to bring in that um, confidence into those leaders, but it is going to be slow because AI is developing, and depending on the kind of complex use cases it solves, it could be for clinical decision or it could be for operational efficiency. Is it for denial or is it for approval only? What are those decisions? It will depend on how the acceptance happens in the industry.
I'd
Great.
like to add one point here,
Yep.
and I would want to divide the whole industry into two kinds of applications. One is where you're making a decision, right? So in those areas where the decision is to be made, the adoption is low. Yes, it's changing, but it's low. Then there is an area where there is a lot of manual work done in the industry, like extraction of data from forms, extraction of data from charts, extraction of data from a lot of things, right? Here the decision is not being made. It's just that the AI can help you read through the different kinds of text or different kind of images or different kind of other media, and it can extract that information for you. So the extraction part, the adoption of AI, ML, and all these things is pretty higher, because there the scope of error also on the part of AI reduces, because it is extracting. If something is present, it will extract. It might miss a few things, but it is not incorrect in that scenario. So it might extract, it might miss, but whatever it has extracted is there in the document to validate. So in those type of jobs, in those type of areas, the adoption is there. But yes, where, as Saurabh said, where decision is to be made, there is always skepticism.
Sure. Okay, next question. Are you able to provide prescriptive guidance about what a care provider should do after recognizing that a patient is high risk so that they can reduce the patient's risk?
So there are two parts to this. Can we? Yes, we can. Specifically, looking at certain characteristics in terms of their high blood pressure, or if they have their clinical or labs data available, what are the things that are leading them to become high risk or moving towards a high risk? Yes, we can. But then it crosses the second line of clinical decision making. Should we right now? Yeah, we can do that, but is that something that everyone is looking forward to? Are clinicians actually asking that an AI comes and tells me what should I do when I'm looking at a patient who's moving into high risk? I doubt the market is small, and but it does not mean that it cannot be done, or it is not being done. It is being done, but the market and adoption is so. That's that space again.
Great. Next question, moving right along. Again, we've got a lot of questions today. And this should be a pretty short question. Stratification model and prediction model is different, correct?
So yeah, I mean, you can call them different. The techniques, however, the statistical algorithms behind them can still be the same. So we are trying to stratify. When we are stratifying, we are classifying the population. It's based on historical, behaviors, historical data accumulated over time. So we are classifying the population into certain categories. That's called stratification. But prediction, when you are trying to predict something which has not already happened, right? So let's say I'm trying to predict if a member is going to be diabetic 3 months down the line. So there, the training of the model becomes a different ball game altogether. So yes, they are different. The techniques, however, could be same. The data could be same, but the outcomes are different.
Great. Next question, we have time for just a few more here, is if my company already has an AI platform, can we utilize that to achieve risk stratification?
So let me take this one. So depends on what do you mean by a AI platform. If the AI platform is already ingesting all your member provider data details, can you build an algorithm and it is modular enough to take that into the workflow? Creating an AI platform that ingests data and can process, you can integrate an algorithm that is doing stratification. But is your platform flexible enough to take that? Is your current workflow flexible enough to utilize that score? Is something that has to be considered. But I am assuming the AI platform that you might be talking about is a platform that contains data and people are able to build algorithms on top of it. That's how I'm considering this.
Okay. Next question here is, how do you manage when you find the data contains quite a good amount of null value, let's say more than 20% of null value, but you do want to consider this variable for analysis? Thank you in advance.
Okay, so when you say no value, it means no outcome because the model is like, it's not just one variable. There are hundreds of variables that go into the model, and then it is trained against an outcome, or it is trained against a categorization, or maybe even, building clusters. So when you say no value, I'm assuming you are saying that there is no outcome. So definitely there are ways in which we can handle that kind of data. We can use that data in unsupervised learning models where we try to train the model based on whatever the input is and how separate or close that input is with with respect to other data points. So there are ways and mechanism we can handle that. But if when you say no value means something else, then if you can
I
clarify,
believe,
we'll have the answer
Priyank,
for that.
if I
Yeah.
understand it differently, no value means for a certain variable that is an important variable, I have blanks. That's what I understood.
Okay, maybe, and there are ways to handle that as well. Statistically, there are ways to handle everything. There are interpolation ways, there are extrapolation ways, and filling up for blanks is like a very common practice that we do in statistics all the time. So yes, we can handle that.
Wonderful. The last question that we have time for today is this one. But again, if you have a question still, go ahead and enter it now, and someone will reach out to you later on to answer your question. But this is the question. To what extent do you see a role for independent verification and validation having a role in the growth of AI models?
Go ahead, Priyank.
Okay, so I would say a lot, and that's what we have been doing with our models. So in most of our models, we have, and specifically speaking about the NLP models, where we are doing a lot of data extraction, we have people who are specialized in those areas. We are sharing our inputs and outputs with them. We are asking them to validate it. We are asking them to give their critical review. We are asking them to help us improve those models. So all these things are very important for any machine learning model, and specifically in the healthcare domain where the scope of error is low, independent validation is important.
Wonderful.
Saurabh, do you want to
Wonderful.
add anything? Yep.
No, I think you covered it.
Great. Well, we are out of time, unfortunately. Thank you, Saurabh and Priyank, so much. This is a fantastic, very meaningful conversation. And as obviously, there's a lot here, and we're going to send out a link to the recording as well as to the slides so that you can review those later. As we close out, though, I wanted to encourage you to head over to vbcexhibithall.com. And what you're seeing right now on the screen here is the virtual exhibit booth for DataLink, and it's there's a lot of really cool resources here. You can read up on them. There's going to be a link directly to this booth on the slides, but you can also find that at vbcexhibithall.com. Again, you can read up on what they're doing, really look at some of the things that they're into, and obviously connect to them through that booth. But if you would like to reach out directly, feel free to do so. Saurabh's email address is here for you, and so he'll be happy to answer any questions that you may have, or feel free to reach out to me. I'm also happy to facilitate an introduction if that would be helpful. So thank you all again so much for joining us today. Saurabh and Priyank, thank you again so much for a fantastic presentation.
Thank you so
Hope you all
much.
have a wonderful rest of your day.
Thanks.
Bye bye.